Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm very excited today to be talking with Dr. Kathy Baase, who's a family physician who I've actually just gotten to know a short time ago. She was introduced to me by Dr. Wayne Jonas, and I've learned through an earlier conversation about some very exciting work and an amazing career that she has had. And this will be an opportunity for her to tell her story. Kathy, thank you so much for joining today.
I am grateful to be here and be part of the amazing work that family physicians do. It's a true privilege to be in this work.
So let's go back to the beginning. Where did you go to medical school? Where did you do your residency? And how did you stumble your way into family medicine?
I went to medical school at Michigan State in the College of Human Medicine, so Michigan State University, and I um, moved on from there. I don't know if you know that there's two medical schools on campus at Michigan
Yes,
State. There's an MD school and a DO school, so that's why I was being specific.
yes, I do know. And then where to residency?
I did that so Michigan State's program had at that time a distributed campus where medical students would do their first couple of years in Lansing, where the school was, and then their second 2 years, their sort of clinical time, that would be done in one of the other communities around the state. I was in the Saginaw campus, so Saginaw, Michigan, and it was called Saginaw Cooperative Hospitals, where we worked with all of the hospitals in the city at that time.
And what was it that drew you to family medicine?
So I had a little bit of an atypical interest in medicine from the very beginning. When I started my journey into medicine, I was really compelled about, about how the achievement of the health and well-being of populations occurred and what were the root causes of that and how to really be more effective, ever more effective in doing that. So when I was in medical school, I was really interested in several things. One, how do we move upstream, so to speak? How do we get ahead in health? How do we be more preventive? And this is in 1980, 81. This is not when prevention was really in the forefront of the thinking around the whole profession. And so I was interested in moving upstream, finding prevention. What were the root causes? How do you get so you're not treating people at the sort of stage where you're feeling like you're tackling something that probably didn't need to happen in the first place. And then the second thing is I was really interested in all of the parties, sort of this biopsychosocial model of health, and thinking about who are the other professionals besides physicians that were important to the achievement of health. And so I was interested in the work of social workers and the work of other healing parties, as I called them, like people that were involved in ultimately that. And so there I was in medical school with both of those things sort of swirling in my head at all times and thinking about where do I go from here and how do I pursue a life in this work and which residency is a good match to doing that. And I couldn't actually find a residency program that, or a residency or a professional discipline that was really about upstream work exclusively and this sort of broader construct of creating health. So I decided to go into family medicine because it would give me the broadest exposure to all of health, and it would allow me the opportunity in the program that I was looking at to do some self-directed electives and to be able to supplement the core curriculum in family medicine with things that would allow me to really begin to push in this space. So that's kind of how I got in family medicine.
Very cool. So, okay, medical school residency, now you've graduated. Then what happened?
Well, while I was still in medical school and even throughout residency, I was always on this line of sight of, well, who's going to actually pay me to do this work that I want to do? And I began to build out proposals and thinking about, well, to whom would this be valuable? And I had thought the way to be a catalytic change agent in this space and really have an amplified opportunity to do this upstream work was I should go into academic medicine, perhaps. And I had come up with the idea that there should be a department of preventive medicine or a department of prevention within medical schools, and there weren't at that time. So I made proposals to the dean of the Michigan State and Wayne State's medical school saying you ought to start a department of prevention, and maybe I could be a part of that, and maybe that would be a path for me. I had also pursued opportunities by meeting with CEOs of the larger health systems and made proposals to them about why and how they should start a department of prevention in their health system, and how that could be an adjunct to creating goodwill, to being a brand differentiator, to being able to connect better with the primary care doctors, that there could be a sort of core set of what today would be sort of back office support for a advanced model patient-centered medical home, where you would have a whole raft of professionals and support that would allow people to really move upstream with their patients and do sort of prospective planning with them and achievement of their highest state of health. And I had also many offers. I mean, the irony of it all was, despite that extreme interest of my work in being upstream, I had amassed some pretty good skill sets in the core world. So I had offers, and I did a lot of moonlighting in a trauma center emergency room. And I had offers from them to work full time in trauma medicine, and had offers in becoming part of the faculty of the family medicine program I was in. So that's where I was looking at it all and figuring out how would I really be most aligned to the very clear, and I had actually written these, my personal career objectives. What I wanted to do was to be a catalytic change agent to stimulate movement in medicine towards more prevention, to be able to quantify the business case for doing that, because I felt like the economics would drive it, and to be able to research and document and report the clarity about the benefits, the economic benefits of the pursuit of prevention. And this whole set of broadening healthcare teams. And so I had these all laid out in sort of SMART objectives. This is in my career, this is what I want to do. And so I examined all these potential opportunities and had every one of these proposals met with success. So the deans said, yeah, that's a great idea. We like your proposal and we'd be willing to hire you for that. And the health system CEOs that I proposed to said, there's a lot of strength in this. And yeah, we'd be willing to hire you for that too. So then I had some decisions to make. And I chose that I was going to go the academic route. And the deans both said, you know, if you're going to really be in a central role in the leadership of the medical school, you need to go take a fellowship program in basically medical school curriculum design and in clinical research, so that you can fit into the expectations here of what's going to be necessary to bring this prevention arena forward. So I ended up going into this postdoc program that at Michigan State. There was one at Michigan State and one at University of North Carolina, Chapel Hill. And I was doing my postdoc, and while I was in the middle of the postdoc program, actually, we had to do real work in this. So I was doing curriculum design work for family physicians in occupational medicine. And because that was a new requirement, that people needed to have training in occupational medicine. So I was interviewing across the country the chief medical officers of large corporations that had in-house occupational medicine programs. One of those was Dow, and I was extracting from them, or intending to extract from them, key information about the skills and the competencies needed for people, and how family physicians could be important in this occupational medicine world, and what would be essential in the curriculum for those family physicians. So what ended up happening was a very unplanned event. I was meeting with this chief medical officer at Dow. His name was Dr. John Lanham. And as part of introducing myself to him, I sent him a cover letter and a copy of my CV. And he was absolutely taken aback by the detail and the clarity in my personal career objectives, which I had added to my CV. And felt that that was a pretty unusual thing. And I didn't even know that it was that unusual at the time. I thought maybe all people did this, but I think now it probably was unusual. And he said, this is a stunning amount of clarity for somebody to have at the beginning of their career about their true ambition and what they want to accomplish. And he said, I would like to hire you, and I want you to do all of this in the company, and you could do it. We have over 100,000 people. This is a closed population. You could do the research you want on the economics. You could basically install efforts to drive the optimal health of this population. You could be involved in representing us in health policy. You could be involved in leading the sort of healthcare purchasing that we do. And so he was making this case about how every one of those objectives could be accomplished by taking this chance of working within a defined population. And he said, this will be easier than if you were in a public health world where you lose people to follow up easily. You have free-ranging humans out there. Here, this is a closed population. Your follow-up studies and your publications would be easier. And so it was so unexpected that it took me 6 months, where initially I just completely discarded it and said, absolutely no, I'm going on this academic route. I have a plan. I'm all clear where I'm going. And then eventually, for almost inexplicable reasons, I said, I think I'm going to try this. And I ended up taking the job at Dow, and it was a remarkable journey. So that's where I ended up. My family medicine residency and moving into a situation inside of a corporation, never losing sight of those objectives. That was my goal. And I was actually fairly straightforward with the leadership of the company, that I didn't decide to come here because I'm deeply in love with your company. I came here because I think I can accomplish these really important priorities for society. And when there's overlap in those, this is going to be great for both of us. And so it turned out there was incredible overlap in that. If you think about it, and I hadn't thought about this before I got there, but that there's very few societal sectors whose interests are as closely aligned to the interest of the individual and their health and well-being. Because if the people have their optimal health and well-being, it really serves the organization well. They make a tremendous investment in the people, and the people are the source of their success. Yes, there's technology and stuff, but ultimately the people are what is the differentiator for the success of any enterprise, for profit, not for profit, whatever. And so enabling those people to be able to have their best whole health, not just the absence of disease, but to be able to function and to understand the magnitude of the economic consequences of that being done well or not is a big deal. And when we looked at, in the US especially, the healthcare costs are so big, which everybody knows. And as an employer, in our case, when we looked at this, just the inflation on that healthcare cost, it keeps going up every year. So the inflation on that spend by itself was worth 6 or 7 cents a share to the company. This is material to the entire profitability of the enterprise. And that's only one way. It affects every priority for a company, their ability to achieve safety goals, because people's health status, what controls safety, people being distracted, fatigued, whatever, those kinds of things factor into mistakes. And so once you begin to understand what are the priorities of an enterprise or a business, and you can see immediately the line of sight to how the health of the people is central to the achievement of every one of them. And so it became really clear about that the pursuit of achieving health of a population at the individual and the group level was a clear overlap to the needs of the organization. And so that overlap was something I hadn't anticipated, but it was very, very clear once I got into it.
So, Kathy, can you give me some examples of programs that you developed and put in place that
Yeah.
had an impact on the health of the employees or the community?
Yeah, I mean, I was there for a long time, 32 years, so there's plenty of that. But I can tell you, just start at the very beginning. I mean, I was in my first year, and for those people who might not understand that corporations actually have significant clinical care in them sometimes, this company had well over 100 on-site clinics that were running for the employees, and we did comprehensive services there. But anyway, I was seeing patients. One of my job was to work in the clinic, and I was seeing patients 4 days a week, pretty much all day long. And I was thinking about the patients that would come in and would talk to them, and they would say things like, "Well, I'm say they're pregnant. I'm thinking I might need to quit my job when I have the baby because I'm not sure how I'm going to care for the baby and be back at work, and I want to breastfeed, and I don't know how this is all going to work." And so light bulbs were going off for me. Well, we need to figure this out. We need to have corporate policies. This is in 1988, right? And we need to have corporate policies that really support women in being ideally successful breastfeeding their children, and it's good for them. And it would be good for the company. They'll retain these people. Otherwise, they're going to lose that talent base, right? Those people are literally going to quit. So in that, by 1990, we were doing on-site lactation rooms in all of our buildings and had corporate policies. And we had purchased pumps that employees would use, and they could check out pumps to take home, and they would get all of their supplies paid for out of our benefit plan. We made it a covered benefit, and getting lactation consultants as a covered benefit, so that we could dramatically improve the percentage of our people that were breastfeeding. And that we had travel pumps. If people were part of their job required them to travel, they could take a travel pump, and we would give them. This is early actions where all it took was understanding what was needed and how that was a benefit to people. So early on, one of the earliest things we did was increase breastfeeding rates for the employees and their families by setting in organizational policies and practices that really made that easier and more successful. And worked with the local hospitals and tried to understand what were they doing to really provide adequate education for people in their prenatal stage. And we began to offer classes on site, prenatal and preconception classes, to have people start thinking about all of these things early on. And we invited those people into the company from the community. So that's the beginning, but that was one of the first things that we did, but I can tell you many more. We set goals and targets to improve access to healthy food at the work site, to improve access to healthy food. We impacted the policies on of the facilities in terms of the design of the workspace and ergonomics, and to decrease musculoskeletal injuries and strain, and the early adopters of sit, stand, desk options for people. And what I learned was that it's not about just what you do in the clinic. Although I was working in a clinic, that the ability to impact people's health was not about what I was going to do by myself as the doctor, or even myself and the nursing staff or whatever, that it was by getting the human resource department to make a policy that was going to be really helpful to the ultimate aims of health, or getting the people who did purchasing and controlled the contracts for food to make policy decisions. And so learning about how to create the environment that really enabled health, and then going and doing that and measuring the impact, even on this initial breastfeeding. We actually did studies. I had a PhD who did a research on the impact of this organizational policy and support. And we looked at absence days and infection rates in the infants of those pre and post the installation of these lactation support rooms and programs, and then tracked the population for years to look at. We actually had improved infant ear infections and other things by that the literature has subsequently correct, but we proved it in our own population as well, and published studies to that effect, and then shared those with other corporations and said, hey, you might want to think about doing this. Look what you can do in a company environment. Ultimately, what we were able to do is to understand the economics of prevention in many ways, and to continue to build upon that and support people in improving their health. We set targets to improve the health of the population through their combination of risk factors by 1% every year. And as you know, generally the population's health has been decreasing by most risk factor measurements. And so we were able to measure improvements in health. We focused on immunization rates and health risk factor reductions, and our influence even with healthcare systems broadly, looking at their own policies on healthcare quality, and trying to deal with C-section rates and that were affecting our population, and how do we go to talk to the hospitals and address those. So a myriad of impacts that you would say are the core work of addressing the health of people.
So if I were to ask you to identify one initiative that people might find very surprising, or that you are the most proud of, does something come to mind, and can you describe that for me?
There were several. I would say creating at the company level a comprehensive health strategy by looking at all of the ways that the company can improve the health of people, and linking all the departments and getting that to be recognized as a true corporate priority, and setting targets for the company on the improvement of health. So I would say that was sort of the central thing to do. As far as actual measurement of health improvement, I would say our tracking of the ability to return people to a higher state of health who were off work because of an illness or an injury or a surgery. One of the things we did was provided them an advocate, a health advocate from our staff in the clinics, whose only job was to support that person in knowing about and accessing all the things that could help them return to their greatest state of health, and to navigate the health system, which is notoriously difficult to figure out how to get your needs met sometimes. And so these individuals who were nurses trained to do this work would be offered as not as a requirement, but as an offer to any employee who was off of work to more than 3 days. I mean, we didn't offer it to them if they were out for a single day, but and we would say, would you like some support? Would you like to have somebody be your advocate and just be with you on your return to health? And in doing that, what we did was tracked the ICD-9 code for every person, like what was the diagnosis. And then we would look at the Presley Reed Disability Advisor, which is a benchmark database in system in the US, and look at what's the typical return to work time for somebody with that diagnosis. And a really important part of it was that our goal was not just trying to find any old way to get people back to work. It was about being of genuine service and improving their health. And it was called Return to Health, not Return to Work, but Return to Health. And by doing that, what we learned is that these health advocates for people and tracking our statistics, which we tracked for the whole US population, we were getting people back to work much quicker than the average. And we were able to quantify the economics of that because all we did was attach an average wage and the days of work saved. And so our typical economic savings on an annual basis was between 10 and $15 million in labor cost savings on an annual year. And yet the main thing that we were doing was improving people's health and enabling them to regain their highest state of function and highest state of health when they had some sort of challenge to their health, be that a major chronic disease or, acute MI or whatever it was, and help them to regain that. And we would also ask for their satisfaction, like, did this help them? And our satisfaction rates were extraordinary, over 96% for years, for decades. And the employees so highly valued this service. And the supervisors highly valued it because they knew that there was somebody there supporting that person getting back to function. And so that's one of the things I'm most proud of, is finding ways that you can document real value, economic value, as you're enabling people's health, and do that in a way that's authentic and respectful and honoring of people, and really deeply caring about them.
Fantastic. I mean, when I think of somebody, a family physician being in a position where you can influence 100,000 lives, probably also it's a larger number because you have dependents. So if mom or dad is doing better at home, or in their life, that means their kids are also having a better life. So that's really impressive.
Yeah.
So you now are involved. You're no longer at Dow,
Right.
and you are doing what you called grassroots community organizing. Tell me about that.
So this is an interesting sort of epilogue, and it's a direct translation of the kind of work I was doing at Dow. So that experience helped me to really hone the business case, economic case, understanding of the alignment of value in health to other organizations. And so what I learned doing that for Dow allowed me to imagine how that same thing could happen at the level of the whole community, that uplifting the health of the population of a community was of real value to the economic success of that community. And in fact, the economic success of the community would drive health. As we know, socioeconomic status drives health outcomes. So how could we move from what's good for a single organization to translating all that same kind of work, policy decisions, at the community level rather than the company level. The mobilization of practices and resources and alignment of efforts to achieve health outcomes at the community level. So this actually began while I was still working at Dow in late 1990s and in the early 2000s. Even as successful as our remarkable health strategy was, where we would literally report on the health of our people and the dollars that we were contributing, the economic benefit dollars that were coming to the company through the improvement of the health of its people, which we would report to the C-suite regularly. This was part of corporate metrics. They said, you've talked to us about all the economic opportunity, and we're making some great progress in the company. We really are. We were holding our healthcare inflation of our benefit plan down to 0 to 2% when others were getting, 9 or double-digit inflation, and we were seeing remarkable results. We had reduced and had benchmark studies showing 17% less chronic health conditions than matched populations in other corporations, like really remarkable outcomes. But they said, tell us how we get even more. And spend 6 months thinking about that and come back and tell us, how do we change the strategy to get an even greater benefit? And I came back and realized that the real way we could multiply this is if the community, because you can only do so much inside the walls of the company. And people's health is still affected by what's happening in the community. It's not just what's happening inside one corporation. So I said, well, what we really need is the whole community to share these kind of goals. And what's happening in the healthcare systems and the way they're operating and their own policies is going to impact this. What's happening in the entire built environment in our communities, all of this is going to impact our ability. And so what we really need is a whole community strategy around health at our major sites, not just a company strategy. That will move us on prevention. That will move us on healthcare costs. It'll move us on policy. And that would be the game changer. I don't know that there's as much more we could do inside the company than we're already doing. We were doing so much and had really mobilized the entirety of culture around health there. And so that they said, okay, go work in the community then. So we began to mobilize all across multiple sectors in the community and established an organization to trial this in Michigan called the Michigan Health Improvement Alliance, a nonprofit, which was established to literally bring sectors together across the entirety of the health ecosystem: mental health, public health, healthcare delivery system, academic health professional training programs, the area health education councils, like the community-based organizations, the entire ecosystem around health. Bring them together and work collaboratively on mobilizing all the assets of the community and moving towards measurable impact. So that work started in 2007 and is still going on today, and is kind of the same sort of journey at the community level that we had kind of gone through, is aligning resources and getting other people to support this work. Just like I told the story of getting the purchasing people to think about the quality of the food that they were purchasing and the cafeteria contracts, et cetera. This is thinking at the community level, right? And so what's our food value chain in the community? What's the locally produced food being consumed? How do you create that cycle in the community? So it's similar kind of work, but doing it at the community level. So that's what I've been doing in parallel to my time at Dow for the last for 10 years while I was still there, and now in a much bigger way, devoting a greater share of my time to that since my official retirement from Dow. And I will say that the Dow platform put me in a position also where I was engaged at the national level in health policy, in working with the National Academy of Medicine, um, heretofore called the Institute of Medicine, and also with many other organizations. And I'm on the National Alliance to Impact Social Determinants of Health. So I became enmeshed throughout the entirety of my Dow career in the public health national arena, in the healthcare delivery system, working with AAFP, with AMA, with the healthcare purchasing world, and with payers and insurers, because of the responsibilities I had there. And also, so you're in healthcare delivery, healthcare sort of systems, public health, and health policy. And in that cross-cutting exposure to how those sort of societal sectors operate, and what are their drivers, and how do you mobilize within them, and then being able to do that in a cross-cutting way, and understand the business and value case there, allowed me to really be with iconic thought leaders at the national level and learn from them, and be able to draw upon that to inform this grassroots work. And then the grassroots work honestly informs the national responsibilities as well. So I now kind of sit in both spaces, as I have for some time, and appreciate, and with enormous gratitude, all the gifts that have been given to me through those exposures in my career.
So could you give me an example? So the Michigan Health Improvement Alliance, it's been around now for a while.
Mhm.
What can you give me an example of a project or an initiative that improved the health, and what would that look like?
Sure, I can. I mean, these have certainly evolved over time, and we continue to do it. And right now, we're in the biggest, most transformative piece of work we've ever been in right now. But some of the early things we did was to look at, okay, so chronic disease. How do we tackle chronic disease at the community level? And we're focused on sustainable system change, understanding what's the sort of milieu of what goes on in the community and what's working and where are the barriers. So we picked chronic disease as one focus, and then we said, let's pick diabetes. What's working to address diabetes? Where are we going upstream or not? And what we saw was that we had a lot of organizations and people working on how do we get eye exams, foot exams, getting to diabetes, medication adherence, and all kinds of things like that. But there was very little in the upstream. How do we deal with prediabetes? How do we prevent diabetes more effectively? And at the time, the CDC was just coming out with the diabetes prevention program, and all of the profound research on that and its effectiveness. And what we looked at was, hey, that's not happening anywhere really in our community. We found out that we had only one person who had ever been to any training about the diabetes prevention program. And so I said, let's take that on. That's a system change. What if we were to imagine a situation where in our community, the norm would be that people that were at risk, that were pre-diabetic, would all be identified and facilitated to an opportunity to reverse their situation or diminish the chance that they would become diabetic. What if we did that? How do we create that being the norm, whereas our previous norm was that wasn't happening? And so we're trying to shift the entire community norm. And that's what we set about doing, was creating widespread utilization of the diabetes prevention program, and doing that through academic detailing, CME programs, to educate people about it so that they would be favorably inclined, by getting a grant to get a set of parties trained to deliver the diabetes prevention program, and to get organizations willing to host that, to be the home of those, and create. And then we extracted the databases, electronic health record databases and claims databases. So employers extract their claims database, figure out who are the people that are pre-diabetic, so that we could create, we know that it's about a third of all adults, right? It's a big population. So we could front load the populations that are eligible, identify them, and make sure that we communicate to them. So you get all these various parties, right? You're working across healthcare and public health, community-based organizations, business, and the payers to come together and get employers to make it a covered benefit. The diabetes, they paid for diabetes education from a certified diabetic educator, was a covered benefit, but diabetes prevention program participation was not. So all of these pieces and putting all of them together is how you do this work at the community level to create a system change that can happen. So that's an early example. Right now, we're involved in an initiative called Thrive, which stands for Transforming Health Regionally in a Vibrant Economy. And that's a radical, big thinking initiative, laser focused on two outcomes: health and economic stability and success for both people and organizations. And we made the case around the economics of this and why that is, and understand that all those parties that are working on business development and economic success, they count on the very same developments, like the root causes. Example, high school graduation is important to the business sector and the economic development corporations and the chambers. That's really important to the achievement of health outcomes as well. And that to recognize the absolute alignment of all of our interests and putting more energy and harnessing that. The same thing with getting not just high school graduation, but getting the jobs and getting people employed, and because their socioeconomic status and their financial stability is central, not just to employment and business success, but to their ultimate health outcomes. So what we've done was bring together an even broader base of the community through a collaboration with another organization that's focused on business and economic development. And we've created a portfolio of actions at the community level that are focused on opioid strategy, maternal and infant health, looking at early childhood investment, and things that are a true balanced portfolio. Balanced meaning clinical and non-clinical, things with short arc of change, short-term payback and long arc of change, things that are focused on individuals and others that are placemaking. So right now we're involved in the biggest thing I've done in my life is this transformative work at the community level.
That's pretty exciting. I'm wondering, have you heard of Harris Rosen down in Orlando, Florida?
I have not.
So let me tell you a quick story. So I've interviewed them. Harris Rosen's an entrepreneur. He's got this company called Rosen Hotels and Resorts. They have about 6,000 employees in the Orlando area. It's the world of Mickey Mouse and Donald Duck and all of the people who provide the support in the hotel industry down there. And about 25 years ago, he got frustrated with the rising cost of healthcare. He was really frustrated.
I think I heard of this. Yeah, keep going.
What he did is he went self-insured, and he sat down with his family physician who was running an on-site clinic that they had there at the time. And he said, "What do you need to be more effective?" And she said, I need more time with my patients. I can't really make a difference when we have these short visits. I need more time. And he said, you've got it. So that was the start of things. And they've grown their on-site clinic. All the employees, if they want healthcare coverage, have to use that facility. They've set up a whole series of arrangements that have resulted in about $300 million in savings over the last 20 years. They took some of that money and they invested it in their employees. So if you're a Rosen hotel employee and you want to go to college after 3 years of employment, you get to go free. If you're the child of a worker, an employee, you get to go free. They've invested in the local communities called Tangelo Park, and they've invested in a pre-K. You know, the little kiddies,
Huh?
they're coming into school with reading levels at or above the other the rest of the population. It's increased their high school graduation rate from 50 to 95%. And you know what that means.
Amazing.
It is
Amazing.
amazing. They've now taken on a second community, and these are communities where their employees live to a great extent. It's a remarkable story. I interviewed them a few months ago, and you know, for I call it conscious capitalism, for a company to say we're going to make money, but we're also going to invest in our employees and the communities where our employees live. I think this is beginning to happen in a number of places, and it's growing. I'll send you a copy of the interview that I did with them, the story I ended up
Oh,
writing
that's great.
afterwards. But it really is remarkable. But it seems to me to align so well with what you and your alliance are trying to do. If you can get the high school graduation rates to increase, if you can get the kids developing and the families developing hope for the future,
Yeah.
that's just a remarkable achievement.
Yep. Absolutely agree.
Cool. So, um, if you were had a chance to talk to a medical student now here you are, you from the beginning, it appears you've been a very atypical family physician, but your core, what I'm hearing, Kathy, is your core philosophy, your belief is that you're a resource for your patients, you're a resource for the community at large, and you've across the course of your career have had an opportunity. I mean, what a wonderful opportunity Dow provided you, serving that number of people. Um, and you had an opportunity to, at least early on, to combine clinical activities with patients with, um, things at a systems level. I'm wondering what advice you might give to medical students who are thinking about the possibility of a career in family medicine and the opportunity to change change our nation's health for the future. Anything you want to throw in on that?
Yeah. I think that family physicians are of extraordinary importance to the health of our nation. And that my advice to a medical student would be to not be constrained by your own framing of what you think you can or can't do, and to not and to sort of take off any mental shackles about what your opportunity space is. I think that the family medicine training is the best possible foundation for impacting the health of people. And so I guess I would tell people is that to think about what you're about and what do you want to accomplish and how are you supporting people, and that most barriers are self-imposed, most of them. And so think about all that you have to bring to serve the population. And there is honor and privilege in being able to use every bit of your capacity to do that in individual patient care. I don't in any way want to undermine that or diminish its value, because it is really deeply important, and we have to have it. I'm just saying that everybody's different in their gifts and their interests, and that to recognize that the full spectrum of what you might do is all legitimate and valuable. And for those people that are the world's best at doing, a core clinical practice, that's tremendous. And for those people who see a different path, I think that we appreciate that as well. And in my career, I've run into many, many, many family physicians in leadership roles, because I've run into so many leaders. And it has struck me over and over and over again how the vast majority of people that are doing this kind of transformative work end up being family doctors. I'm always amazed at it.
Me too, which is why I want to tell your story, and I want to tell some of these other stories. It is just amazing to me what family physicians are capable of because of their broad skill set, their broad vision, and their willingness to be flexible and adaptive to the opportunities that arise, and the opportunities are always arising. So Kathy, I want to thank you very much for talking with me today. This has been fabulous to get to know you. And I look forward to continuing to talk. There are a number of ideas that are swirling around in my head as I've been listening to the kind of interest that you have. So thank you very much.
Well, I appreciate it. Look forward to your follow-up and the story from Posen in Orlando. I can't wait to read that as well, or learn more about it.
Send it out to you this afternoon. Kathy, thank you very much.
Thank you. Bye-bye.